Thank you very much, Dr. Snyder, for your kind presentation. And I would also like to thank our friends from Jafron to organize this symposium. And now we're moving on to the presentation, and we're trying we will try to answer or to see what hemoperfusion can offer us in the setting of the critical patients. Hemoperfusion is a blood purification technique. We know this technique from long ago, and contrary to the conventional blood purification techniques, to convention and diffusion, this technique is based in absorption. It is also known as hemoabsorption, and is basically used in the removal of toxins in poisoning and in cytokines in septic and inflamed patients. We have different devices available in the market. There are some of them they are built as fibers, other are as beds, granules, or other forms, and all of them, as it is a very versatile technique, it can be used as a standalone therapy or combined with conventional renal replacement therapies, and even associated with cardiopulmonary bypass. Regarding the mechanism of absorption, this mechanism it works in different steps. I think it is important to know what this technique, how this technique works, and knowing this, perhaps we will be able to imagine the settings in which it will be useful. In the first phase of this absorption, the toxin is bulked from the fluid to the outer surface of the absorber, and followed by a diffusive movement from this outer surface of the absorber to the internal part of the porus. In a different phase, this will be followed by a binding, different binding mechanism, fundamental, based in ionic and van der Waals forces, but the main mechanism is based on the hydrophobicity. There are not specific indications of hemoperfusion in the critically ill patient, but in the recent years there have emerged different indications that in these few minutes we are going to have a quick look. Perhaps the use of hemoabsorption in poisoning is the most widely spread indication, at least in the past years. All the information we have from this indication is based in retrospective studies, so the information we can extract from this is quite limited. For example, we have this study about paraquat poisoning, and it was made in 4 centers, and patients were allocated into 3 different groups: conventional therapy, or a second group associated to hemoperfusion, and a third group where they combine hemoperfusion and CPBH. What they got in the results was that the levels of paraquat at 72 hours after the initiation of the treatment were lower in patients with hemoperfusion or hemoperfusion combined with renal replacement therapies. Also, there was a significant improvement in the SOFA score in patients treated with these 2 kinds of therapies. What we can extract from this study is that in certain type of poisonings, hemoperfusion can offer a a quicker elimination of the toxin when it's associated to conventional removal therapies. Also, all these findings and they were accompanied by an improvement in survival in these two groups. But even if it is the most recognized indication, what we can see is that even when it is indicated, there is a very low use of this therapy when it could have played a role in the treatment of certain patients. Regarding the liver disease, it sounds quite logic to think about this therapy, and during the past years there have emerged different kind of liver depuration systems, and it's a therapy that we don't have we don't have a lot of data to set a recommendation, but it's a therapy that in these years it might be a promising therapy. One of the fields that has emerged with power in the last years is the potential role of hemoperfusion in those situations with systemic hyperinflammation, like IRDS, pancreatitis, cardiac surgery, major burns, or sepsis. And we are going to have a look through a few of them. About IRDS, unfortunately, most of the studies have failed in proving an effective reduction of cytokines between patients treated with hemoperfusion and conventional therapy. Perhaps in these studies, it's quite logic to think that perhaps there is a problem in the selection of the patients and in the selection of the initiation of the therapy. As far as we know, the dynamics of cytokines, it is important to start the therapy when the levels are high and when they might be correlated with the clinical state. So some studies, perhaps, they have a bias in this about this. Other studies have tried to study the effect of hemoperfusion combined with ECMO, and we have all kinds of results, from those who couldn't prove any benefit and those who find some benefits more related with improvement in hemodynamics or respiratory parameters more than in mortality. But the main problem of most of them is that they don't provide a single measurement of interleukins. And when we are talking about a technology based on elimination of certain molecules, if we don't measure what we say we are trying to eliminate, it's quite limited the conclusions that we can extract from the study. Other studies, they have found effectiveness in the reduction of interleukin levels, but when they compare the results in the group where they patients treated with hemoperfusion, they find that in that group of patients they could divide it in two groups: the ones who improve and the ones who didn't improve anything. They found differences between the group of patients treated and not treated, but they couldn't find significant difference between the patients treated with hemoperfusion who improve and patients treated with hemoperfusion without any improvement. And we also can find studies with incredible results, but without providing any single measure of cytokines. The conclusions that can be drawn from these studies, they are very, very limited. About cardiac surgery, it's a field that has been explored largely with hemoperfusion, and finding a good correlation with improvement on mortality, it's difficult to find. Perhaps it is not the right outcome to measure in this kind of patient. We have several studies that they have shown that other clinical outcomes can be possible and they are important to measure. For example, the doses of cytokines the doses of vasopressors, they are correlated to the levels of cytokines, and it was also related to the length of stay in ICU and the days of mechanical ventilation. And regarding sepsis, it's not easy to talk about the role of hemoperfusion after the publication 1 year ago of the recommendation of the Surviving Sepsis campaign, where they said that hemoperfusion with polymyxin B, it wasn't, they didn't recommend the use of polymyxin B as a treatment in septic patients. It is, we can debate about this for long, but there's a second part in that recommendation that, or where they said that they couldn't recommend anything or couldn't set any recommendation about other blood purification techniques, that including other devices. Here I bring two, I think there are interesting studies from Dr. Sao. They are very well conducted studies. They are prospective randomized studies with more or less the same scheme of treatment, where patients were allocated to conventional treatment or conventional treatment plus hemoperfusion. In this one, they measure IL-6 and IL-8, and they proved that hemoperfusion was effective in the reduction of these mediators. One of the problems of this study is that the population is quite heterogeneous. We have abdominal sepsis, respiratory sepsis, and other kind of sources of infection. But in all of them, what they found, there was a significant reduction in patients treated with hemoperfusion. And they also award us about the possible side effect, like the drop in the platelet count. A second study, in this case with respiratory sepsis, here in this case they measure TNF and IL-1. The scheme of treatment, it was the same, and they found improvement in respiratory parameters and hemodynamics, and this was correlated also with less duration of mechanical ventilation, of renal support, lower length of stay in ICU, and lower mortality. I think that they're quite good results. But one thing that we must take in account is that not all sepsis are the same. And what I mean is that even there might be a potential role of this therapy in sepsis, it doesn't mean that it is for all septic patients. Because one thing that we learned from the definition of sepsis given by the last consensus conference on sepsis is that the problem is not the infection itself, it's how the patient react to the infection. And the main thing is that there's a dysregulation on the host response. So it's something that we must take in account, that the same infection in two different patients is not the same. And related to that, we know that all infections have different patterns. Not all infections have the same inflammatory degree. And in this line, sorry, in this line we know that, for example, abdominal sepsis has higher inflammation pattern, and also is accompanied with more coagulation disorders, more activation of complement, more oxidative stress, and of course more cellular damage and death. So to know which kind of patient is appropriate for this therapy, we are in the right time to conduct rigorous and serious studies to identify which patient could benefit most from this therapy. This is mandatory. For this, it's mandatory to select an homogeneous population, trying to enrich the sample with clinical criteria, also biomarkers, and perhaps including a genomical approach to select the right population to conduct the study, and trying to find optimal endpoints at the beginning, probably related to levels of cytokines and other outcomes, and finally translating these results into clinical endpoints. I would like to give a brief comment about our experience with this technology. We are very restrictive using this technology. We restrict its use to abdominal sepsis with patients with this criteria, and we follow this scheme of treatment. We consider up to 4 cartridges, but usually we don't go beyond the second, because the improvement of the patient and the measurement of inflammation. In the last 2 years, we have received 45 patients with abdominal sepsis. Only 9 of them meet the clinical criteria and the basic parameters of biomarkers. I mean, procalcitonin and RCP. And when they meet this criteria, we measure IL-6. From these 45, only 9 meet the criteria, and only 5 have an interleukin-6 levels above 2,000. Our experience with these patients, as I said, is quite good. All these patients, they are still alive. We have seen a dramatic drop of the doses of vasopressors following the reduction of IL-6, and clinically what we see is an improvement of the signs of hypoperfusion, and it's quite spectacular sometimes. But we have also seen what other authors confirm in their study, that there is a dramatic drop in platelets and a trend to lower in albumin. But both, they recover after the interruption of the therapy. Just to finish, we are in a time that we are facing an exciting challenge, like defining the role of this therapy in critically ill patients. We have to define which patient is suitable for this therapy. We have to search for the right indication, the right moment, the right duration of this therapy, how to follow the result of the therapy, which is the most suitable biomarker for this, and all the potential side effects of this. As a conclusion, there's only one accepted indication for this therapy, and although it's accepted, it's poorly used. We have current low level of evidence supporting this therapy. We don't even know how it really works, but it seems that it's a technology that is effective, reducing the levels of cytokines. But if we use this therapy with this objective, it should be carefully monitored. And to finish, we need a specific criteria to define the usage of this therapy. Thank you very much.